you are there. Nicholas.
Yes, I'm around, sir.
Okay.
Trying to join with the laptop so that would be more of a wider space, sir. I'm around, sir.
Okay. Nicholas, are you there? Right. Victor, are you in? I can see today obviously has joined. Yes, sir, obviously. Right. So this is a live session. Okay. And it's a mentor, like it's I mentor to to help you. Oh, you're welcome, sir. So to help you to understand physiology. My favorite subject is physiology. Okay. So maybe in future I will do my PhD in human physiology. Okay. Then a little bit of philosophy to teach in education. So that will be my dream. Okay. But before I become a full-time teacher, I want to gather I want over millions of people to listen to me so that I teach them for free, no matter where you are. Okay. Yeah, no matter where you are. I like to teach a lot of people. Okay. Yeah. So if you want to benefit from me, then when you pray, pray for me to get long life, to stay strong, and also to know more so that I can teach you. Okay. Right. So welcome to Bright Education Consult. We have started the journey of maternal health. Okay. So yes.
Please, yesterday I couldn't join the class. I tried to access the YouTube and I realized that it's only 33 minutes of the class that we did. So
Really? What
I
happened?
would like to know
Okay.
if you only did 33 minutes of the class.
No, we did, I think, 1 hour. So I'll post the original link to the page.
Okay. Okay.
I'll post the link to the page so that you get a full class.
Okay.
Yeah. Thank you so much for letting me know. Right, so let me share. Right. So we started with maternity 3. Please mute yourself. Ayariga. Control for me. Made you a co-host. So take control of okay. Great. So we started with maternity 3 yesterday. We dived deep into the physiologies, the medical conditions, the complications. Okay. So today we're gonna continue. Where did you reach yesterday? I remember. Yeah, I think here. Pulmonary embolism. Okay. Pulmonary embolism.
Yeah.
Why pulmonary embolism? We started from DVT. Okay. Deep vein thrombosis. And we said that okay, thank you, sir. Right, so deep vein thrombosis. Yesterday, we realized that for somebody to get thrombophlebitis, okay, we have the superficial and the deep vein thrombosis. Okay, so we also realized that a clot, most of the times when the clot detach itself or breaks and is circulating in the blood, the places that it can easily get locked in the lungs. Okay. So we realized that if I do a D-dimer test and it's very high, there are two specific tests I need to do as a follow-up. I need to do a Doppler or duplex venous test for the deep vein thrombosis. Then I have to also do a CT of the chest or CT angio, okay, to know is there any clots in the lungs as well, okay, or the pulmonary system. So let's start with what? The pulmonary embolism today. Yes, this is the lungs. And this is the heart. The heart is bringing blood to the lungs. Okay. After it brings blood, the oxygen here will diffuse into the bloodstream and the carbon dioxide will go out. CO2 will go out. Okay, like that. Okay. Right. So after the oxygen takes over, so let me make here CO2. CO2 will go out first. Then oxygen will come in. Okay. So after the oxygen is picked up, the blood here is called oxygenated blood. Okay. This one must go back to what? The left atrium. Then systemic circulation goes. But a clot can block this side. Clot blocks this side. What now happens? Person or the pregnant woman will be having sudden shortness of breath. So you and I can be talking now, all of a sudden I can't breathe. I can't breathe. Okay. And because I can't breathe, or because I am not getting oxygen down, what now happens? The tissues here begin to die. They begin to die. And when the cells begin to die, I told you yesterday that pain is a vital sign. Pain is equal to vital sign. That means something is what? Dying or spoiling. A tissue is dying or spoiling or damaging, whichever way you want to say it. Okay. So if the cells here are dying, definitely I'm going to experience what? Chest pain. The heart has seen that there is a problem here and that all the oxygen, the blood that is coming back to the heart is full of carbon dioxide. Okay. So what is now happening here? The heart will attempt to pump fast and very strong so that it can remove this clot. Okay. That is what? A compensatory mechanism by this heart. The heart is very lovely. It always tries to help us when we are in trouble. Okay, beating so fast and hard will give you what we call tachycardia. I remember there is one thing about the heart muscles that, yes, they will try to help you, but when they are tired, they will give up. Okay, so they will give you the reflex tachycardia If you don't do anything about it, you start getting arrhythmias, then cardiac arrest. Okay, so you see what? Tachycardia. Then hemoptysis. Okay, you see a patient, the capillaries, some of them will be bursting, blood will be coming here. Okay, the patient, when the blood comes here, or some of the fluid exits here, the patient, it will become a foreign body. So patient will begin to what? Compensatory. What can the airways also do? A foreign body in the airway, the body will naturally what? Stimulate the coughing reflex. The coughing reflex. Because yes, the brain has seen that there is a foreign body in the airway. Oxygen is stuck, it cannot go down. The capillaries here, there is a lot of stress, inflammatory response going on there. Okay. Yes. The fluid is moving, capillaries are bursting, blood is moving into the airways. Okay. So you cough it out. Coughing it out, you are going to see what? Some stains of blood in it. Okay. Yes. So that is what we call hemoptysis. Let's look at psychological. Patient will be like, what is happening to me? What is happening to me? Am I dying? Feeling of discomfort. Okay. So there will be anxiety. And remember, this anxiety will go and top up the tachycardia and it will shoot the heart rate up. Patient will be feeling very discomfort. Okay. Feeling heat, not paying attention and all those stuff. And feeling of doom. Yes. I should tell you that the patient is having what? Pulmonary embolism. So you, the nurse or the health worker, you must act fast. One of the cardinal signs is what? Shortness of breath, sudden shortness of breath. That's why I've highlighted it for you to know. We have medical conditions that can give you chest pain. Pneumonia can do that. Okay. Other conditions that can give you tachycardia, yes. Other conditions that can give you hemoptysis, yes, tuberculosis. Other conditions that can give you anxiety. One of the cardinal signs, pulmonary embolism, is sudden shortness of breath. And your saturation will be dropping down. At this moment, what can I do as a health worker to help this patient? Do I need to leave the patient and go and do other things? Or what? So let's go down and learn more. Elevate the head of the bed. Okay. Then you administer oxygen. Why are we elevating the head of the bed? Okay. The patient is lying down. This is the bed with your head like this. And let's say this is your lungs. And your heart is here. Okay. Or your heart is here, whichever way. So once you are lying down, this pulmonary vessel is going to be like this. So this is where the problem is. Okay. This is where the problem is. The clot is here. So remember, there are alveoli here. There are alveoli here. There are alveoli here. There are alveoli here. And some too are here. Okay. But because of your position, you are in that supine or lying position. The body finds it difficult to what? Saturate or receive oxygen from the alveoli at the top because you are lying. Okay. So what now happens? If I elevate the head of the bed, let's say I elevate it like this, 45 or 90 degrees, and now your head is here, your lungs are here, and your heart is here. The same problem is here. But because I have elevated it, I will be receiving blood from this side. So this problem is still here. Okay. But I am able to receive oxygen and other stuff from this, the alveoli that were at the top here. I can get saturation, okay, from the other alveoli. And the patient will be relieved a bit. Yes, relieved a bit. It helps me to buy time. But it doesn't mean that the clot is gone. Okay. And I told you that when the body starts making clots, it does it faster. Okay. So what can I do to stop more clot formation? I need to give a medication called heparin. And what did I tell you heparin do? Heparin will slow down clotting formation. It will slow down clot formation. Okay, yes. So the clot that is already in the process of forming, it will slow down. And the ones that are not yet formed, it will prevent it from forming. That's it. So it's a journey. Some of the clot are here. Some are on the way. This is the final destination. So this one has gotten to the final. I'm traveling from Canada to USA. Okay. My destination is USA. If I get to USA, I'll cause chaos. So some of the people have gotten to USA and they are causing trouble. Okay, for you, we will deal with you. Those who are on the way coming, heparin will slow them so they can't come. They can't get to USA. And those who are packing their bags in their rooms in Canada to start the journey, heparin will prevent them from even getting into a flight moved. So that's what it does. So that is the power of heparin. So when it happens like that, your first bolus, your maintenance. But I told you, you should know the actual weight of the patient before you start your heparin. It's very important. You should also do your CT, your oxygen. Remember, once you put the patient, you elevate the head of the bed like this. Now I have other alveoli that can what give the pulmonary circulation or the pulmonary vessels oxygen. So yes, give oxygen and let the alveoli at the top here receive oxygen and give it to the hot pulmonary vessels to send it. But remember, this clot is still here. And you call what? A problem is on the way coming. That's a trickle. A problem is on the way coming. So doctor must be called. But you, the nurse, you act first, elevating the head of the bed and also hot oxygen administration. That is my trick ever since I knew this. If you know physiology and you understand anatomy and you understand pathophysiology of conditions, you know this trick I'm telling you. Okay. When a problem happens or a complication happens, doctor must be informed. That's the first action. But when a complication is about to happen or a problem is on the way coming, what do? You, the nurse, act first before you call the doctor. Then you prepare for anticoagulation. Then you do continuous monitoring. Quick. I don't want to waste your time today. Let's go. So your bed rest, elevating the legs above what? The heart level of venous return. Apply warm compresses. Initiate heparin infusion. Then you monitor for signs of pulmonary embolism. Do not massage in case of DVT. DVT, do not massage, okay? Then avoid prolonged sitting. These are the things to do so that you don't develop or you don't form clot faster. Okay. Early ambulation, postpartum, pregnant women. So let the pregnant woman walk. Don't wait for the pregnant woman to get DVT. Because once they get DVT, we restrict their movement. Hydration is very important. The blood should not be thick. When blood becomes thicker, it will form clot. Avoid crossing the legs. Then compression stockings post-op, not during acute DVT. Very important. Okay. So they will say, I have a question here. A postpartum client report unilateral calf pain and swelling. What is the priority action? Who knows? Postpartum, yeah, somebody should give me the answer.
Bed rest.
Okay. Bed rest. Okay. So unilateral symptoms, DVT, those of you who like the quick takeaways, the warm compress, superficial, whatever, then that's it. Pulmonary embolism is an emergency. Never massage any painful legs. No walking in the acute phase. No pressure on the limbs. Okay? Good. Let's go to the next complication. Let's leave the clotting issues and go back. Now, woman has given birth. We are looking at some of the complications they can get in the pregnancy journey. Okay. A woman can rupture the uterus like this. Okay. The anterior aspect of the uterus, look at the leg of the baby. It is torn. Wow. And look at the blood vessels. And this patient is bleeding into what? The abdomen. So let me tell you something. Yes, patient will be bleeding into the abdomen. So your tummy is not bleeding outside this tummy that you see. Okay. He's bleeding into the abdominal cavity. So the trick that they used to get a lot of people is that this muscle that has torn, it won't be strong again to contract. So you get what? Uterine muscle flaccidity. It will become weak. Please, do you understand? The abdominal muscles will become hard. Let me draw it. This is your abdominal muscles. This is your abdomen. This is you. Okay. Your abdomen. Okay. And you have your uterus here. The uterus is torn. So you are bleeding into what? The abdominal cavity. Yes. Aside all the signs and symptoms, I know what I'm saying. You will get this uterus. It will not get the strength to what? Contract. So you get what? Uterine flaccidity or uterine atony or to be that bogus lifestyle. Okay. Soft. But what about these muscles of the abdomen? This one, your abdominal muscle here. How about it? It will become hard. and tender. Okay. So you can go and meet a question. They will give you all the signs and symptoms of what? Uterine tear. And take away uterine flaccidity. But they rather give you what? Tenderness of the abdomen. It is a trick. Okay, I was telling someone the other time that you can learn KO Bank. Okay. And KO Bank will give you one question every day. Okay. But for example, malaria. Let me talk about those who are going to write exams. When somebody has malaria, he has headache, he has fever, he has body weakness. Okay. He has fever, body weakness, all these what are some of the signs and symptoms? Okay. But joint pain, okay, nausea and vomiting, yes. Anorexia, yes.
Anemia.
So when we want to list the signs and symptoms of malaria, we can get thousands of signs and symptoms. Splenomegaly, all these liver issues, jaundice, yet we can get it. This is what maybe kill. I'm not saying kill bank is not good. That kill bank we are learning. Somebody has sat down and loaded the website with 4,000 questions. Out of these 4,000 questions, those of you who want to do tutored tests without no timing, they will pick out of these 4,000 some questions and give it to you. Those of you who want to do timing questions, they call it the cat, the nut, whatever, the cat, they will pick some for you to do. It's the same question. Take your time and go through all their questions. Go through all. You realize that you are seeing the same question repeating itself. Okay. So you can be getting 90%, 80%, okay, all these, but when you go to the exam, Bank gave you what? Malaria, all these signs and symptoms, and you were always getting it right. You were always blowing, so you think you know. Now you go to NCLEX or your licensing exams, whichever country you are going to write. Okay. These signs and symptoms, they can bring you, NCLEX can bring you nausea and vomiting, fever, body aches, okay, joint pains, and tell you to diagnose it. Because you are familiar with everything. When they gave you part of it, you became confused about what is going on. The NCLEX is difficult to is it how this? So they will pick some. That's why I always encourage you. Yes, you do your questions, but be a master of the game. Understand physiology, because physiology is the foundation. If you don't understand it, you will never know. Okay. Back to uterine tear or uterine rupture. 20% of cardiac output go to the gravid uterus. Gravid uterus, a uterus with a baby inside. Okay. So imagine if the heart pumps, boom, 20% of that cardiac output is going here. I want to scare you so that when you meet this condition, you don't delay to kill somebody's mother. Okay. If my heart is pumping one pump is the ejection fraction is maybe, let's say, I don't want to say in percentages, let me go volume. So the ejection volume, example, if it is 1,000, 20% comes towards the uterus because the baby is inside. So that would be 200 for one pump. Boom. How many pumps can we get in 1 minute? We can get 60 pumps, 200 pumps. So if one pump is bringing 200 mils to this whole uterus, and this uterus is torn, under 1 minute, how many blood or how much blood will flow into the abdominal cavity because of this tear? Can this woman survive uterine rupture? Look at this, the length of the tear. This is a cross section. Okay, tear. Can this woman survive in the next 30 minutes without you replacing the blood or fluid or the blood volume, circulatory volume? So that is why we say it is a medical emergency. Okay, let's go down. Learn more. Learn more. So uterine rupture, all these ones. Okay, yes. The full thickness tear of the uterine wall, most often during labor. So pregnant women, when we say don't push, don't. When we say push, push. When we say pant, pant. Okay. Yes. Allows the fetus to wholly or partially extrude into the hot abdomen, which results in severe maternal hemorrhage and acute fetal hypoxia. Yes. So this patient, the patient will be having severe hemorrhage and the baby inside will be drinking a lot of blood. Okay. Can get hypoxia and die. Okay. So previous CS. Previous CS. It makes, I told you that for if I cut this uterus, you came for CS, I cut it. For this CS to repair itself and be like it has never been before, or for this uterus to repair itself 100%, it should take me like 2.5 years and above. Some books will say 3 years and above. So your wife delivered 1 year, the first pregnancy, CS. 9 months, this woman is back again with another. Should we allow this woman to deliver per vagina and give all these contractions and all? Oh God, if you stress the muscles of the uterus, this site that was treated some months or years ago, it will tear. And when it tears, you put the woman under hot. So the scar gives way under hot pressure. This scar that you think the woman's uterus has healed. Okay, that's it. Then uterine surgery, myomectomy, fibroid, and all those stuffs. It also weakens the uterine wall. Then excessive oxytocin, it causes hyperstimulation. Okay. Yes, so we say contraction should not last more than 90 seconds. If contractions start 0 seconds, and the highest contraction should go is 90 seconds. How much is 90 seconds? Convert 90 seconds to 1 minute or to minutes. It will be what? 60 plus 30. So 1 minute plus 30 seconds. A normal human being who is a mother or a gravid uterus, when it's contracting, it should not cross 1 minute, 30 seconds. If you have contraction continuously, sustained contraction for 2 minutes, guy, you are weakening hot. It is muscles, so they are cells joined together. Okay, so if you give it too much pressure, it will tear. That elasticity will break and it will tear. When it tears, you try and rupture. Prolonged or obstructed labor, it causes uterine stress. Then over distended uterus. Yes, those pregnant women who will be eating. Because you want your baby to be okay. Multiple gestation and polyhydramnios. All this one causes that. Okay. Then we have trauma. Can also cause that. The multiple or grand multiparity also causes that. So VB plus sudden pain plus fetal distress will lead to what? Uterine rupture until proven otherwise. Until proven otherwise. If you have any question, keep it. Okay. The classic signs and symptoms, and it's very tested. Take note of this. So your licensing exams will ask you for mothers, sudden severe abdominal pain. There is a tearing of muscles. You and a pregnant woman, you are sitting down, all of a sudden, complain of severe abdominal pain. That pain, she has never experienced it before. When your muscle tears, the pain it gives you, you've never experienced it before. I should tell you that no. Start thinking about uterus. Cessation of contractions, especially mothers in labor. The contraction will stop because I told you once the uterus tears, the muscles of the uterus doesn't have the strength to contract again. Atony. There's vaginal bleeding. So you are bleeding into the vagina and bleeding into the abdomen. Signs of shock. So tachycardia, as in reflex tachycardia, then hypotension, because you are losing what circulatory volume. Then loss of uterine tone. We've said that. Then palpable fetal parts. That is when the uterus, like this one. Okay. If you put your hand on the abdomen, you feel the fetal part here. You feel this leg. That trouble has come, Charlie. Let's go to hospital. Okay. Then for the fetus, there's going to be fetal bradycardia. Okay. Fetal bradycardia. Because the volume of blood that should go from the mother to the baby, some is passing, a chunk is passing away. Okay. So if this is the arterial supply and blood is out, an artery with not enough or less blood, when you feel the port of that artery, it is called what? A weak ready pulse. Some people will say imperceptible. Imperceptible pulse. So if the mother's artery is sending blood to the baby and something happens and the artery tears and the blood is oozing out, diverting, what will happen to the child? The child will be having what? Fetal bradycardia. Bradycardia. Okay. That's very important. Then loss in terms of this thing. If the baby, if it was labor, now the baby will move up. Patient occurs at the ischial spine. And I told you when I engage you, you should be at the 0 level. So -5 to 5. Yes, +5. So if I am here, if the head is here, and there is a tear at the top here, the head will go up. So you are not going to experience station again. Because the head, the baby will move up. Okay, yes. So loss of fetal station, the midwives know how to do it. After labor had been progressing, start thinking about what you trying to. We have a placenta abruption. A lot of people get confused. Note the difference. There is pain. When we take pain, uterine rupture will give you sudden tearing pain. But placenta abruption will give you a constant. Okay. Yes, the pain doesn't stop. Then, when you take the future, when you take the index contraction, for uterine rupture, once the uterus ruptures, all the strength will vanish. Okay, there's uterine atony, so contraction will stop. But for placenta abruption, if placenta tears, it is not the uterus that is torn. So contraction will continue. The fetal heart rate, there is sudden, because of the uterine rupture, there is sudden severe bradycardia. But over here, we will get fetal distress. What is fetal distress? The heart rate of a child or of a baby or a fetus is 110 to 160. If it goes up above 160, we call it fetal tachycardia, FT. If it goes below 130, fetal bradycardia. So what is distress? When the heart rate is swinging between tachycardia, bradycardia, tachycardia. Today is up, tomorrow down, tomorrow is up. Patient is in distress. Okay. Yes. You check for the movement to sometimes. So all these ones you should know. Then the shape of the uterus or uterine shape. This one is abnormal. It become boggy, abnormal shape. But abruptio is rigid. Okay. Scar. Those of you who do one previous whatever uterine surgeries, the scar can rupture and cause uterine rupture. Here, it is the placenta that detaches itself. So note the difference. NCLES will give you what? This difference. Then you will pick one, especially NGN. So note the difference. Now let me move fast. We have 1 hour. So immediate nursing action. When you see any rupture of the uterus, it means what? A complication has occurred. So provider must be called or doctor must be called. I mean, this is not a time of nursing action. Okay. Always note this trick. A complication has occurred. Doctor must be called as soon as possible. That's the first nursing action. Call the doctor before you go and do any other thing you want to do. But a complication is about to occur. Do something before what? Before. So, I have a contraction. Example, I have a contraction that is lasting 2 minutes and it's not stopping. My uterus is not ruptured. There is no rupture. Okay. No rupture yet. But because of this sign I am seeing, if I am somebody who is clinically good and physiologically good, I know that if this contraction should continue, the uterus will rupture. So it says that what a complication or a problem is about to happen. At this moment, are you going to call the doctor? No, that should not be your first action. Because this one says that what a problem is on the way coming. Okay. So let me do something. You are in your house and you saw a storm coming. And you have your money in your wallet here. You are standing here and the storm is coming on the way. The storm will take like 1 hour before it gets to you. Won't you take your money and run away? You will take your money, you will act, you will do something first before you run away. The same house you are inside this house. The money is here. You saw a storm. You opened your door and you saw a problem, a big problem at your door, a storm. You don't have that space to go and look for money. You run away immediately. This thing happens. So a problem is on the way coming. You do your nursing actions first before you call the doctor. But a problem has come to you, bam. You don't have time to do nursing action. So let's relate this scenario to this. Contraction is lasting 2 minutes. So contraction is here. This is the woman. Okay. What are you supposed to do? You stop your oxytocin. If there is any uterotonics, you stop it. Bam, first nursing action. You won't call the doctor to come and stop this oxytocin for you. Stop it. You, the nurse, act first. But you didn't do anything. And now the contraction has ruptured the uterus. And the woman is bleeding into the abdomen, per vagina. The baby's leg is out. That is not when you are going to look for oxytocin and stop it as your first action. You should call the doctor first. This is the trick. This is a live trick I am giving to you. You don't learn this thing only when you are going to write exams. You are taking care of human beings. Okay. So know every condition you treat. Ask yourself, what are the complications? If you want to be a best nurse, let me tell you something. If you take any condition, okay, when you go to work, you see so many people on the ward with their conditions, okay. Definitely, they will not ask you to look after everyone. They will share the job. So if I were you, the condition is you. Okay, ask yourself, this patient has malaria. That's the condition. What are the complications? The next question you should ask yourself, what are the complications of malaria? So these are the complications. Okay. Somebody cannot just jump from malaria and the next moment there is complication. No, there should be a journey. There should be a linkage. So the linkage is the signs and symptoms of complication, an impending complication. So if you take malaria and the complication is splenomegaly, what are the signs and symptoms of an impending splenomegaly? So you should know splenomegaly and know the signs and symptoms of an impending splenomegaly. So once you start seeing the signs and symptoms of the splenomegaly coming, you should act as a nurse, do something. But if you were so busy and you did not know, and now you have seen that there is what? A splenomegaly, maybe a lab result came, and you saw, or we did abdominal CT, and you saw that the spleen has enlarged, doctor must be know, because complication has occurred, doctor must know. But when you see the signs and symptoms of an impending complication, act as a nurse first before you call the doctor. So let's go back. We are not switching. I've used 7 minutes to explain this to you. Open your eyes here. Okay. So let's go back to our uterine rupture. Rupture has occurred. You don't have time. You see this alarm. Doctor, first, before you go and do anything, okay, if you are in a big hospital, rapid response. Okay, rapid response. And every hospital should have a rapid response. Yes. You should have day shift, should have a rapid response team. Night shift, rapid response team. Okay, very important to save lives. So everybody should come to your aid and help you. Don't be proud, don't be pompous. Are you a nurse that somebody can correct? Are you a nurse that somebody can direct? Okay. So don't say that you are the head of the shift. So you will not listen to anybody's advice. You are killing somebody's breadwinner. Okay. Then after you've called the doctor, you stop oxytocin, apply oxygen. We've done all this physiology, so you know. IV access. IV access, very important, large bore. If the vein, superficial veins collapse, okay, if your superficial veins collapse, I've told you yesterday, I explained to you, we have every human being has superficial veins and we have deep veins. So when there is massive blood loss, the superficial veins will collapse. Majority of them will collapse. That is not the time you are going to waste. You are going to use 30 minutes to look for IV line on the hand. Master, you are wasting time. Somebody will die on you. Okay. You need to go to the deep veins. You don't have time for this. Go to the deep veins. What are the deep veins? Where can we get the deep veins? You can get some at the groin. You can get some here as peak line or midline. I have a note for you guys. One of these days I'll call for town hall meeting. Okay. You can get your jugular veins here. Under the clavicle, you can get your subclavian veins here. Or you can do your port. Yeah. Those of you who are very good with bone IV line, you can do your intraosseous. All these veins are here. What are you waiting for? Oh, the doctor, let us get what? Central line. So all these are central lines. Or there are some veins that are deep that you can use ultrasound to get it. But the question is, how many minutes are you going to use to do ultrasound? Because this uterus is bleeding. If you are fast, you can get ultrasound IV. Okay. Yes. So these are all some of the veins that you can. The central lines, the deep veins that are inside the body. Some people have a lot of fat. Okay. Their skin is so tough that their veins are deep. So you do. You prepare for emergency CS, fetal heart rate monitoring. Then you prepare what massive blood transfusion. But you are giving blood, plenty blood. Remember to give plasma. Okay. You can't give plenty blood without adding water. Okay. So you can't give plenty red blood cells without adding water or plasma. You go and cause what we call polycythemia. Polycythemia has increased risk for what? Clotting. the blood will become thick and the platelet will start sticking to each other. They will clot. So you need plasma. That is why anytime we do massive blood transfusion, we should give what plasma concentrates to dilute the blood. Note this in your IV fluid. Note that. Okay. So prepare for that. Do not attempt vaginal delivery when you start seeing. Nobody will do that. So we've done these ones. Prevention, careful monitoring of VBAC patients, avoid excessive uterine stimulations, continuous fetal monitoring during oxytocin, very important. Then immediate response to abnormal fetal heart rate. Okay, so all your VCHOP, the VCHOP, variable early decelerations, late decelerations, and all, it. Okay, so this one too, So another question. A client with a previous CS suddenly reports severe abdominal pain. Contractions stop. The fetal heart rate dropped to 80. This is cardiac arrest. A normal adult with this heart rate is perfect. We salute it. But a baby cannot take this heart rate. In fact, okay, a baby with this heart rate, the baby is almost dead. What is your priority action? Who knows? Yes. The mother is presenting this to you. You are the nurse on duty. You just came to work, you took up. You've not even eaten maybe you came for afternoon shift. So you've not taken your afternoon diet. A mother is presenting this to you. What will you do?
I think I called the primary healthcare provider.
Yes, you call the doctor because what? This is a clear sign that what? The complication has occurred. Okay. So for you to know any condition, ask yourself, what are the complications of this condition? And what are the signs and symptoms of the complications? If you want to be a germ, then you always have to read. You always have to read. Okay. If I take fetal distress, or let's say uterine rupture, UR. Okay. The uterine rupture alone has what? Signs and symptoms. Uterine rupture is a complication. So the complication has what? Signs and symptoms. But uterine rupture will not just get up and do rupture. No. There should be a labor. Okay. There should be what? A previous CS. Okay. So this is where the journey started from. All the patients who come to you in hospital, their journey started from somewhere. But because you are not living with them, some of them will come to those who are very good, who we call them doctor shoppers. The listing, they will come to hospital, so they mostly come in the beginning of the journey. But those of you they don't have money, they don't have all these, from their house to hospital is too far, insurance issues and all, they won't come. So they will come in the complication state. So you, the nurse, you should know, okay, if they come at the beginning of the condition, what are the signs and symptoms? You should know the signs and symptoms of the beginning of a condition. If they come, and after knowing the signs and symptoms, you should see ahead that, okay, what if the patient comes with a complication? What are the complications of this first stage of the journey? Okay, the complications are uterine rupture, whatever. Okay, uterine rupture. I've noted down in my small diary. What are the signs and symptoms of an impending uterine rupture? Then you write it down. You make that network. And what are the signs and symptoms that a complication has occurred? The uterine rupture has occurred. So NCLEX, that's the trick I'm teaching you. I don't want you to fail NCLEX because this is how they do it. The question you are reading, first ask yourself, which stage is this patient? Is it at the beginning stage or the complication stage? Because safety is always the denominator. If the patient comes at the beginning of the journey, you do cross. At least I have time. I can relax and take care of this patient. I don't have to call rapid response. I have to take my time. But if they come at the complication stage, you don't have time. It's a medical emergency. Okay, it's a medical emergency. Okay, then you ask yourself, now, person has come at the complication stage. What are the signs and symptoms? The question in front of me, is the patient presenting the signs and symptoms of a complication, signs and symptoms showing the complication has occurred, or a complication is about to occur? See, today you should count yourself blessed for being part of this class. Because after today, the way you learn will change. The way you learn will change. Because if you don't know what you are doing, somebody will slap you on the word when tensions are so high. And later they will come and say, sorry, but it has already occurred. Okay. I have seen situations that health workers, because of a patient, health workers are using instruments to fight, and the patient is on the theater bed. Because complications have occurred, break instruments, you are now relaxing. Delaying. Okay. You are delaying. I can check the live stream if it is still ongoing. Because yesterday someone said it stopped. So this is what you should know. Okay. Okay. So like Victor said, this question, Victor is so, he knows what he's doing now. So for seeing the question, he has seen that what a complication has occurred. So my first action is to call the doctor. This is not rocket science. You don't need engine. You don't need kill bank to know this. So even if you go and they change the question, they should take some of the signs and symptoms out. Look at this NCLEX question. This is the pure NCLEX question I brought to you. That's why I wrote NCLEX practice question. So when we say uterine rupture, uterine rupture, we saw plenty signs and symptoms of what? Uterine rupture. But the question, the NCLEX people, they took some of the signs and symptoms. But because Victor knows all of them, he saw that no, this rupture has occurred. Because they told you what? The patient reports sudden severe abdominal pain, 1. Contraction has stopped, 2. Heart rate drops to 83. They brought you only 3 signs and symptoms. But we saw plenty signs and symptoms. So that kill bank you are learning, is it the same signs and symptoms they are giving you? The kill bank is also giving you the other aspect of these signs and symptoms. But because you are always attached to that kill bank and you are getting higher marks, you think you know. You don't know. We will change English for you. And you will find them. They will change. Sometimes they can pick the subject and give you the synonym. That's why you should master your English too, because synonym, that's a lot. They can change English. Okay. And see if you know what you're doing. So please blend it. Blend it. Okay. So endless takeaways. uterine rupture, stop pitocin, CS, then this is a fatal or okay. Then uterine atony. Atony means the muscle is tired. What is causing the muscle to be tired? Is there bleeding? We know already that bleeding will stop. Bleeding will make your muscles, the uterine muscles tired. They will even stop contracting. Prolonged labor, first stage. In the first stage, active phase, latency, or transition. Once it delays the uterine and you give birth. So let me relate this to labor has started. Labor has started. You know that once labor has started, you are in the first stage. So the first stage has 3 stages: the latency, the active, and the transition. This labor crossed the latency stage. Now, so 3 cm. When labor got to the 4 cm stage, it is supposed to journey from 4 cm to 7 cm. But we say that every 1 hour, it should move what? 1 cm in the active phase, approximately, if labor should be normal. But this active phase has lasted for what? 6-7 hours, still in 5 centimeters. Victor, what will you do? Should tell you that once my labor has lasted long in this active phase, it is the muscle of the uterus that the energy is wasting. So once I have a delayance here, it means that I can get a problem here in the transition phase. Okay. So transition phase, I can get a problem here. Or stage 2, I can get a problem. Okay. So you now ask yourself, if there is a problem here, what is the likely problems? What are the likely complications I can get here? Then you note it down. What are the signs and symptoms of the likely complications I can get here? That a complication is about to occur. Then you write it down. Okay. The next phase is stage 2. Mother is delivering. Mother's uterus can get tired and it will not contract again. Okay. You can get tired. Or the mother's uterus can deliver the baby, and after delivery, it can get tired and it will not contract to stop the bleeding. So I'm expecting what? PPH. So all these things, you have prepared yourself down. So once the woman can never dodge it when you prepare yourself. Once you see the signs and symptoms, you know that this one has up. So don't wait to see PPH. The journey started from somewhere that you are seeing the PPH now. So this PPH means complication has occurred. So call the doctor. Please, do we understand? Let me know. Send me a note in the chat box for me to know that you understand what we are doing today. So you go to your licensing exams and they will bring you a question with signs and symptoms that PPH is occurring. Okay. You know what to do. And they will ask you, what is your priority action? And you hear people learning kill bank and they will be arguing, oh, let us go and read the rationale. Let us go. Somebody will be shouting at the back, let us go and read the rationale. Let us go and read the rationale. Even they got the answer right. But let us go and read the rationale. People like rationale. Yes. Let us go and read the rationale. I have stopped teaching people English tricks because I realized that, especially the questions, I realized that when I started teaching people the tricks, they were not coming to class again. They would rather go and pick the questions. Oh, okay, if you see this and this, you do it this way. You see this and this. No, I don't want you to be a robot nurse. Because the day they will change English for you, you'll be stuck. If you do that, you are doing robotic nursing. You are a robot. We configure you. Then you work with the configuration. Okay. Right. So that is what you should know. Okay. Right. So you try attorney, one of the most common causes of PPH. So you should understand. So these are somebody is massaging the fundus of the uterus, okay, just to make the body hard. They are all there, okay. How can PPH occur when there is uterine atony? Okay. I explained this yesterday. I don't know if you were there, but keep the question. I'll explain to you, okay. The uterus to contract, this is your answer, resulting in heavy bleeding. So let's go to the uterus. Let me answer your question for you. You see the uterus? This uterus has an artery and it has a vein. It has an artery and it has a vein. So you see your uterus, the person who asked the question, if you are a female, this is your uterus. You see how blood vessels have surrounded your uterus. Okay. All these arteries are bringing blood to the uterus. And all these veins are taking blood away from the uterus to the heart. When the uterus become tired or not, the heart of the mother is still pumping blood. So the blood will keep coming. It will keep coming. It will keep coming. Okay. Once the baby is out from the whatever, V or whatever, okay. When baby is out, the mechanism of labor causes some minor injuries and blood tears, especially at the capillary. You see the capillaries here, these tiny blood vessels. Sometimes some of the major vessels even tear. But when they tear, remember, these blood vessels, they are coming from the outside of the uterus and they travel across the muscle layer. So it's like this. If this is the muscle of the uterus, the blood vessels are the arteries, they are traveling from the outside of the uterus to the inside. They are traveling from the outside to the inside. So once the baby is out, what is the work of the uterine muscle to stop this blood from flowing here? The uterus must contract. And when they contract, they close, they squeeze the blood vessels so that the bleeders will stop. And once you squeeze it, clotting, whatever, physiology, cascade or whatever, it will occur. And this bleeder will stop here. So henceforth, you will not see any bleeding going on. Now, he is out. The uterus, we have given you massage the fundus. We have given you uterotonics, oxytocin, pitocin, whatever, EGOT, cytotech, whatever. We have given all these things. Still, the uterine muscle is tired. And because they are tired, they can't contract. So if you can't contract, the blood, the mother's heart it doesn't care. If you don't contract, that does not mean the heart should stop working. It will pump blood. That's where the PPH comes in. Postpartum hemorrhage. Please, the one who asked the question, let me know if you understand so that we continue. You have 30 minutes to leave. Okay. I always wish you understand what we teach, not to just open a slide and finish the slide. If you finish the slide and you go and they ask you a question and you can't answer, that is a waste of time. So let me know, yes, if you understand that physiology. Good. Yes, so you should know what is going on now. That is why we massage the fundus of the uterus to get the body hard. So you see how thick the muscles are. So if these muscles want to squeeze an artery, where is the strength of an artery? Okay. If these muscles squeeze, remember the blood vessel, the arteries are coming and they pass here. Sometimes they come here, especially if there is a placenta. Placenta is here and the baby is here. So the muscles can squeeze and block the arterial supply. And when that happens, what's the name? The umbilical cord will be in trouble. This is the placenta, this is the umbilical cord. So once I block this artery, the placenta is not receiving the blood it wants. And we are not getting enough blood here because the blood supply has been cut. So what will happen to the baby? The baby is going to have a fetal heart rate dysregulations. So medicine will come. If the muscles are contracting, what is the fetal heart rate doing? Because once the muscles contract, as you see an immediate effect on the fetus. And how can you know that the fetus is healthy? The fetus proves healthiness with its heart rate. So it is something that occurs at the same time. If I give you medication and it hardens your uterus, as you see a reflection on the fetal heart rate. Okay. So contraction and fetal heart rate. When the uterus is contracting and I see a fetal heart rate, I know that the contraction will stop. So the fetal heart rate will continue. So I'm not bothered. In situations that fetus hasn't contracted, it has not started contracting. Okay. Okay, so let me make it like this. Let me make it one line. This is contraction and this is fetus. So I see a contraction as you see a fetal heart rate in this same angle. Karen. No, contraction has occurred. I did not see fetal heart rate. It was after the contraction I saw fetal heart rate. What is causing that? When these muscles were contracting, why is it that blood was still passing through the arteries here to the baby? And why is it that after the contraction that I am seeing the fetal heart rate, the blood supply cutting off? So we call it what? Late decelerations. I am seeing the fetal heart rate dropping after a contraction. Okay, so we have this view chop, whatever, view chop. Okay. What is the P? Who knows the P? If I get late decelerations, what is the P?
Placenta insufficiency.
Yes. Okay. Or some will say prolapse, whatever. Any decelerations the fetus, the muscles are not contracting. Okay, but heart rate is dropping. So if this is the contraction, I saw the heart rate of the baby dropping down, dropping before the contraction came. What caused that? That means something is happening, and it's not a problem of the muscles of the uterus. This is physiology. If you understand these things, you stop all these acronyms, VCHOP, whatever. Okay, so in maternity, early is accepted. We salute it. Okay, yes, the pregnancy is from the uterus, not from the uterus, but we accept it. Then we monitor the baby to see if the drop will further go down. Because most of the times, when you change position, sometimes the mother will even be lying on the left side. That I am blocking. Okay, contraction has not occurred, but remember, these blood vessels are coming from the heart of the mother. Okay, they are coming. So what if those blood vessels that are coming, some has blocked, something has blocked it here. It has not reached the uterine side, but once something blocks the arteries of the mother, supplying blood to the baby, the heart rate will drop. Okay, so you can see that the muscles of the uterus of the mother, they are not contracting, but the heart rate is dropping. In this condition, we call it what? Early decelerations. Okay, so just change. Tell the mother, can you turn yourself? Is the mother lying on the left side? Is the the mother lying on the right side? Okay, let me give oxygen to the mother. Positional changes. Life goes on. Okay. The contraction, let's come back again. Contraction is happening. I have seen fetal heart rate dropping. It means that, oh, okay. We all know that contraction, quarter contraction should last what? 1 minute 30. This 1 minute 30 seconds cannot kill a baby. So we will keep watching. So it's accepted. We salute it. Okay. Yes. Then we have what? Contraction has what? Happened. At the same time, I was expecting the heart rate to react, but nothing came. That you are seeing what? Heart rate occurring after the contractions. I should tell you that I have issues, placenta. I have issues. What is going on? Okay, this is a late deceleration, so everybody becomes eye-opened, eye-red when I see late decelerations. You do all your maneuvers, then you go. This is just by the way. Okay, so 8:20, we have 20 minutes to go. 10 minutes for lectures, 10 minutes for uh, then we go away. Okay. So leading to postpartum hemorrhage can progress rapidly to hypovolemic shock because of PPH, then requires immediate nursing action. Very important. Okay. So what are the factors to PPH? The uterus over distended, so it's now tired. It cannot go back. It has become flaccid. People carrying twins. People have plenty amniotic fluid. Polyhydramnios. Baby is big because mother was eating, had sugar is gone up. Okay. So baby received a lot of energy to metabolize. So baby is having plenty cells. So baby has become big. Okay. And plenty fat cells. Prolonged labor, you can't dodge PPH. When you stress your uterus and labor prolongs, muscles will be fatigued. So be expecting it. Precipitous labor. Labor occurring less than, some say 3 hours, 4 hours. At this stage, we say the uterus has drank cocaine. You know, people who drink cocaine, they take stimulants. Cocaine is a central nervous system stimulant. Okay. People who drink this cocaine and marijuana and all this, give them work, they will finish within seconds. But when they want to sleep, when they are tired and they sleep like crazy. This is the same thing that happens to precipitous labor. You don't have to chew this, relate it, and you are done with the topic. Okay. The midwife give the pregnant woman something to speed up labor. Okay. What is the nature? What is the physiology? Okay. What is the DNA of this woman? In their family, they have precipitous labor. Okay. Some people have small babies. So the uterus doesn't contract properly. Then high dose of oxytocin, grand multiparity, you decrease your uterine tone. Then chorioamnionitis, infection, muscle inflammation. Then operative birth, CS, and cause trauma, bleeding, and all these things. So boggy uterus, English will bring the English, boggy uterus plus heavy bleeding. It doesn't mean that every day you are going to see this. They can change English for you, but these two are cardinal. Expect what uterine atony until proven otherwise. Okay. So, what are the normal labor hours? Oh, you are not here. Which country are you? I'll answer you, don't worry. So in abroad, we go to work how many hours? 12 hours. Okay. So if labor should be normal, it should not cross your shift. That's it. So labor starting 6 hours, 12 hours, we move. Do you understand? Within this time frame, if a normal human being, normal labor, 6 to 12 hours. So in US, we go to work, nurses, we work 12 hours if we were to work on the ward. So labor should not cross your shift. That's it. Please, do you understand? Yes, I've given you the trick, so you live with it till you die. Okay. So signs and symptoms. So you know what these ones. Fundus above the umbilicus, heavy vaginal bleeding, large clots, PPH, hypotension, hemodynamics, dysregulation, tachycardia, pallor, and dizziness. So you see dizziness, that should tell you that the central nervous system has involved themselves in the problem. So be expecting so much to happen. Bleeding can be internal. You can see with your eyes. The uterus may feel enlarged even if the bleeding looks minimal. Take notes. So immediate nursing action. Patient is bleeding. You have given birth. This is the uterus. Inside the uterus is bleeding. Okay, you put pad there. Okay, you do your estimations. So you went to check or whatever, 100 mils, 200 mils. Okay, 300 mils. Pad, we check it hourly. Okay, hourly checks. So 200 mil, 300 mils. Ideally, every hour, the quantity should reduce, not to go up. That should tell you something is on the way coming. Okay. Every hour, I went to check the woman's pad. If the first hour I got 100, okay, with cloth. Cloth 2 is another indicator. The next 1 hour, okay, I check. So, and it should be less than the 100. But you went to check, it's now 200 or 150. With plots even higher than the first one. Third hour, you went to check 300 with clots, plenty clots. Victor, this should tell you that what a problem is on the way coming. So what is your first action? The nurse must act before they call the doctor. Call the doctor. So your fundal massage. But when you hit the 500 mark, or it becomes plenty, the patient starts showing what cardinal signs of PPH. Complication has occurred. So doctor must, that is not the time you are going to massage fundus. Call the doctor before you come back. Then you are massaging fundus, calling rapid response. So massage first before medications when problem is on the way coming. That's it. So fundal massage, empty bladder, okay, straight catheter if needed. Then administer, you know this one I explained to you last time. So administer uterotonics. So these are dates. Avoid ergometrin. In hypertension, you blast somebody's arteries in the brain. This one, it increases the blood pressure. Okay, patient already has hypertension. Don't push stress on the cerebral arteries. Then carboprost or herbamate, avoiding asthmatics. Okay, it can trigger asthmatic attack. Then what? Misoprostol or cytotec. Somebody is asking, so we have entered the question time. Somebody is asking, let me finish it too. IV fluid is very important, blood product, but remember your plasma if you do massive transfusion. And continuous monitoring, okay, for lochia and all these guys, okay. Then medication, cytosine first line. Then ergot, carboprost, or you have all these medications to give. Then difference between proper and other PPH courses, the 40s, you know it already. So uterine tonicity, the trauma to the uterus, the tissue, placenta tissues entering into the bloodstream, causing issues, then thrombin, okay, or retained placenta, yeah. If you retain placenta, you are in trouble. So uterus is firm, but you see bleeding. You massage your uterus. There's bleeder. That means that there is somewhere in the vaginal canal or the birth canal that is torn. The uterus is just here. But when we come below the uterus, you see the cervix. That's the mouth. You see your vagina, the blood, whatever, all these tissues. So yes, when here tears, you see blood coming out. That doesn't mean that the fact that blood is coming out from here, the uterus should be bogus. No. So that's what you should know. Okay. So with uterine issues, empty your bladder to make the head and the body firm. Early ambulations, control cord traction, then prophylactic oxytocin after. delivery. Okay, these are the tricks. Those of you who want the chill and pour lifestyle. Okay, I have created this for you. Okay, my last question. A postpartum client has heavy bleeding. Look at the question and ask yourself, is this a complication question or a complication is on the way coming question? A postpartum client has heavy bleeding and a boggy uterus. What is the priority nation? So you should understand this before you answer this. So Victor, shoot, if you are there, is this a complication question or a complication is about to happen question? If you always think this way, you know where you should take your answers to.
So I think this is a complication.
What makes it a complication and what complication are you looking at? You should justify your answer.
A postpartum client has a heavy bleeding. I mean that the complication have already occurred. That's what I'm thinking.
Oh, so you are looking at the heavy bleeding.
And the boggy uterus. And
so what complication is this when you combine these two? Yes. Any idea?
So you trying atony?
Okay. What makes it uterine atony, but not vaginal bleeding or vaginal tear?
The uterus is bulgy.
Process bulky. Yes. If your vagina tears, your uterus will not be bulgy, to be firm. So the fact that you saw heavy bleeding does not mean uterine atony. They added this one as a cardinal sign. So now, uterus bulgy, heavy bleeding. Okay. I am having heavy bleeding and I'm having boggy uterus. Is this a complication question or a complication is about to happen question? Yes, Kajit. Is that your name? Answer. If you don't understand it, you can.
It's a complication question. But the bleeding is heavy. Because they've described the bleeding as heavy, which is combined with a baggy uterus.
What will you do?
So I think it's complication.
Okay. Any other idea?
Sir, I've changed my mind. I think that the complication is about to happen because this one will lead to hypovolemia. Yes.
You see how they trick you. Yes.
Yes, and then you have to intervene by massaging.
Yes. So this is a grammar question. Hey, Jesus. This is a grammar question. They qualified this, but they did not quantify it with a number. Do we understand? Yes, Victor is right. Okay, let me give you another. Let me change this English and explain it to you. We know that vaginal bleeding 500 is what? pph. Okay, pph. This heavy is an ambiguous qualifier. So somebody has 300 mils vaginal bleeding. Can we say they have pph? Yes or no?
Say no, but it can progress to pph.
Yes. No, because the 300 is heavy, but it hasn't hit the mark of 500. It's not that you don't know. You know. You are good. But sometimes they use English to change the whole narrative. Okay. So I am having heavy bleeding. Okay. Every woman who menstruates, or majority of them have what? Heavy bleeding. But the question is, because you're having heavy bleeding, does that mean you are going to, or you've gotten a shock? If you are menstruating and your menses is heavy, is it equal to shock? You are on the way of getting shock, but you've not hit the mark of shock, hypovolemic shock. Okay. So now answer your priority question. Hey, are you scared? Don't be scared. If you learn this way, you go and write in class and you'll be smiling. Don't worry. Let us not scare the nursing students who have joined. Okay. Charlie, the job with you. Now answer questions. Do you have any question?
All right.
Yes.
And please, if my memory sets me right, yesterday when you were teaching, you said like if someone delivers and the person loses 500 mils per vagina, that is by normal birth, it is normal, and then if it's 1,000 by CS, it is normal. That is how I understood it. So what you are talking about, is it post, like maybe after birth, the blood, if you measure the blood that is coming and it is 500, that is, I mean, pph. I want to know the difference. Thank you.
I didn't say it's normal. I said
Okay.
if you hit
Okay.
500, it's classified as
Okay.
PTH.
Okay. Okay.
For vagina birth, then 1,000 is what? CS. Okay. Any question?
Okay. Okay.
So,
If we don't ask me questions, why? I'm Feriana. Yes.
yeah,
Oh,
so
you.
you made mention of surgical emergency, and I've also seen medical emergencies. I think you've also mentioned it before. So, in what cases do we say that this complication or this condition is a surgical emergency or medical emergency? Like, how do we classify it? Thank you. And also, is it only these two? Is it only surgical and medical, or we can have like psychiatric emergency also? Like, I just want to know is that. Thank you.
When we say this is a surgical emergency, okay, it means it needs surgical intervention, immediate surgical intervention. And when we say a emergency is medical, it means it needs a medical, so a medical intervention. Okay. Psychiatric emergency, like psychosis, hallucinations, they need what? Psychiatric interventions to survive, to protect safety. Okay. Example, somebody has gone a big tear, a big tear, let's say uterine rupture. This is a surgical emergency. Why? Can you give oxytocin? Okay, let me go up. Will you give oxytocin? This is a tear. Immediately it tears. The uterus, if it is contracting, it will stop. The muscles of the uterus will be flaccid. we know that any uterus that is weak and flaccid, you can give what? Oxytocin to make it hard. Will you give oxytocin for this scenario?
No, sir, because there is already a tear. No, you will not give.
This is a surgical emergency. The only way you can protect safety, like anklets, safety is the denominator. The only way you can protect safety is to choose an answer that will properly protect the safety. That is why you need what? Emergency what? Repair. Okay. To repair this. You understand it? Okay. The uterus is intact. Some blood, when we took out the placenta, okay, some bleeding is occurring. The same bleeding like this, but the muscles of the uterus are intact. I am seeing blood here. Okay. I don't have a tear of the muscles of the uterus, but I'm seeing bleeders. What can I do? I must give what? A medication, or I must do a balloon tamponade. Okay. Block this bleeder. Block this bleeder. Or I must give oxytocin. Okay. To make, or cytotec, whatever, misoprostol, to make the muscles of the uterus hard. Did I take this patient to theater? No. Did I cut the uterus to repair, to suture these blood vessels that are torn? No. I used the medical means. So I got an emergency, but I used the medical way to intervene. So we say, this is what a medical emergency. Do you understand?
Yes, please.
Yes.
Yes, please.
A mother came to your clinic who is 35 weeks. Okay. Carrying the baby. Yeah. But per your assessment and per scanning and everything, you realize that this amniotic sac has ruptured. So amniotic sac is gone. Amniotic sac is gone. The baby is now exposed to infection. Okay. Yes. Will you say that because the amniotic sac went away, let's take the mother to the theater and repair this sac? No, you do that. That's not a surgical emergency. It's a medical emergency. Give you antibiotics, IV fluid. Okay. That's it. So then a woman has given birth. Okay, I'll come to you, Alice. A woman has given birth. After giving birth, the hormone dropped down. And now this woman is having what? Puerperal psychosis or postpartum depression. Okay. The woman has gone and thrown the baby away because she is so depressed to the sense that she is not interested in anything around him or her. Sorry. Okay. And don't say that because they are depressed, they will like their baby. If they don't like their clothes, if they don't like food, they won't like the baby. They will throw the baby away. It is one of the cardinal signs of what? Postpartum depression. It's a major depression. Will you take this woman to the theater to do cranial surgery?
No, sir. No.
Okay. Will you take this woman back to the maternity unit to give oxytocin or folic acid? So I need what we call psychotherapy and antidepressants for this woman. Okay. That's it.
Okay, sir. So, sir, please, with that being said, uh, if you get a question like delirium, is delirium a medical emergency or psychiatric emergency? What is the best option to choose?
Yeah, somebody should explain.
So,
Delirium.
Brian, I would say it's a
want-
medical emergency because it's
Yeah,
as
so
a result of like a medical condition and it's short-lived. It goes away once the person is getting better.
so yes, it's a medical emergency. Delirium is always caused by something. Is it infection? Well, I always tell you, I don't know whether you were part of the class when we were doing delirium. Scan the body from head to toe. Okay. Go inside the body, take blood, go and do labs. Take urine, go and do labs. I mean, do your CT. Do you want to find a problem? Okay. Until you find the problem, the delirium will be hunting the patient. Okay. But adults have proven themselves to the way that anytime they get UTI, people above 70 years, okay, UTI, you will get issues with delirium. Once you treat the UTI, the delirium vanishes. So I don't need you to give psychiatric medications for this. Treat the problem. Okay. That's it. Even dehydration can cause delirium, can make you delirious. Yes, next question. If no question, thank you for joining. Okay, let's see how the day goes. So I lecture Mondays to Thursdays. Okay. Then nowadays, sometimes we do town hall meetings. Nowadays, I'm going to make it more regular. Okay. More regular for town hall meetings. Town hall meetings is 30 minutes to 45 minutes. Okay. So please, if you are on the page and you see town hall meeting being scheduled, don't engage. If you are a group which uses the Zoom and you see town hall meetings, please, and we will try our best. It's not going to be an impromptu meeting. We will try our best and schedule the meeting there. Let's say 4 or 5 hours ahead. Okay, so that it will not be like, no, we don't want you to use the Zoom link. Okay, so please, the videos are online. Go and watch it. You share and you like the page. Erica will be sending the links to the page. If you join today and you are not part of the WhatsApp group, Erica will put the link on the chat box of this Zoom class before we leave. Click on it. It will take you to the WhatsApp group. When you join, don't join to share anybody's group there. You don't want that. If you do that and admins take you out, don't blame me. Don't blame them. Okay. You join, you can share any health. You can share your mind. You can bring questions. If you have any doubt, you can bring it on board. Somebody will help you. Okay. So please, let's take notes. Let me see. Where did we get to? I don't want this slide to cross to next week. Where did we get to? So okay, let me see. Good. Tomorrow, let's meet. Okay, and finish this slide. We are not supposed to meet tomorrow, but tomorrow I'll meet you. The same time. Okay. So we have tomorrow, we are just coming to meet to complete. We have reached the 18th page to 25 page. Then we say goodbye to maternity. I don't want to post any link maternity again, please. So tomorrow, I beg, let's meet so that next week, Monday, we start what? Pediatrics. Pediatric. Now a baby is born. We should know how to take care of the baby till the baby grows. So please come tomorrow. Let's meet. Thank you. I'm out.
No, sir.
My name is Paul Bright, your registered nurse. Yes. Any question? Is it Lois?
Yes. Yes. Good evening.
Evening.
Yes, I kept the question on the chat, but I don't know whether you have attended to it.
Oh, what was the question? Let me see. Is it Alice? Let me go
Yes.
through. Alice. Which patient will you prioritize between a patient in shock and the patient with uterine rupture? Which patient will you prioritize? Uterine rupture and shock. Wow. Yes.
Sir,
A
I'll prioritize shock.
patient is in shock.
Okay.
Shock is an organ damage. Uterine rupture, the uterus itself has not even damaged. Talk of other organs. For you to get shock, so many organs should damage and it will give you shock. Okay, this is the human body. It has a liver, it has a kidney, it has, give me some of the organs. What is this? Charlie. It has so many organs, plenty organ A, organ B, organ C, liver, whatever, the brain, the heart, and so for you to be diagnosed as shock means what? This organ is compromised. This one is compromised. This one is compromised. Two or more organs, we compromise, we damage it. As a result of they are not receiving blood. Okay. Or the blood, the nerves that are supplying the heart, either the heart or the blood vessels have been blocked. Because of that, the heart cannot pump to send blood. Because of that, the vessels cannot contract to push blood. Okay, yes. So when that happens and these organs damage, we insult them, two or more organs damaging. At the same time, the body will enter into a state of shock. You understand? But uterine rupture, this is the same human body. This is my uterus. The uterus has ruptured. It is what? Bleeding. My heart is intact. My liver is intact. My everything is intact. It is only the I'll throw away this guy. I'm going to listen to this guy. But in triagen, when triagen comes in, the scenario changes. I'll look at the rate of survival. This guy's organ, liver is damaged, kidney is damaged, this one is damaged. Why should I waste my time to revive this patient? Meanwhile, I can stop bleeder and this one can continue life. So I'll put this patient on blacklist in triagen and prioritize this patient. So where the question is coming from. A patient is brought to the triad or there is an accident scene that you went there to triage. You prioritize this. But when the question is not about triaging, triaging means which of them will I give? If I have an egg, that is an egg of life. This is an egg of life. You are holding it. I come so many patients. Which one should I give life to so that they will continue? If I go and I see an adult and a child, adult, you have enjoyed life for long, go and die. Child, collect the egg. Let's go. That is it. So, Alex, do you understand?
Yes, sir.
So, yes.
Thank you so much. Thank you so much.
Good. So when they bring the questions to the ER, shine your eyes because they know why they have mentioned ER sometimes. Okay. Or when they add triagen, whatever. I mean, any other question? If no questions, then I stop the share. And good night. So tomorrow we are meeting to complete this slide. I don't want to enter tomorrow next. If you are watching me online, I'll be coming to answer all your questions, me and my admins. So please drop your questions there and it will be answered for you. Thank you.